तुम आ ही नहीं रहे हो अजीज। अब ना शरीफ देखो हजरत, मेरे पास आप अटेंडी आ ही नहीं रहे हो। री इन करो शरीफ, रीज्वाइन करो, रीज्वाइन करो।
Hello. Assalamu alaikum, dear colleagues. Let us begin the monthly CD meeting under the auspices of Pakistan Orthopedic Association, Karachi chapter. It's an honor to be the host for this month. Our section has collected very valuable case materials from across all subspecialty disciplines of orthopedics, and I'm sure it will be worth a significant lesson for postgraduates to take home. So we will begin in the name of Allah. I would request Dr. Mari to say a few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم هو الله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم صدق الله العظيم.
Jazakallah, Dr. Marij. I would be requesting Dr. Rufina to be the moderator for today's meeting. She is our chief resident, finally a resident who's just passed her FCPS Part 2 exam in the last March and Feb FCPS exam. So she will be coordinating today's meeting. Over to you, Doctor.
Chief Resident at Al Khan University Hospital. Welcome you all in the city-wide meeting of hosted by Al Khan Hospital. So we designed pieces which was alphabetically arranged around the specialized spaces such as arthroplasty, foot and ankle, and hand and wrist. So we will start our presentation for the arthroplasty section. And I would like to invite Dr. Ahmed Ghazni, our three residents, to come and present their case.
So, Assalamu alaikum everyone. As Dr. Rufina mentioned, my name is Dr. Ahmed Ghazni. I'll be presenting a case of total hip arthroplasty in a dysplastic hip. And my topic has been supervised by Dr. Mujahid Jamil. So starting with a brief history of this patient, she's a 34-year-old female and a teacher by profession and a resident of rural area of Balochistan. The patient presented to us in the clinic with a progressive bilateral hip pain and significant difficulty in walking. She also mentioned that she now thinks that she's homebound because of the pain, and this debilitating pain cannot let her mobilize freely. And she has only limited mobilization left with the walker only. And she's been taking multiple regular analgesics, and the pain has been refractory to the analgesics now. On examination, she's a young female with a BMI of 30.2, and her gait was intalgic waddling gait. And on the examination of the spine and the knee was normal, and she has painful range of motion of both the hip joints. On calculating the limb length discrepancy, she has about 75 centimeter limb length of our right and 73 centimeter on the left. She has fixed flexion deformity of hip and both the hip, about 20-30 degrees, and the hip flexion is significantly limited to 18-90. Abduction is about significantly reduced. As you can see on the right side, it's 0. On the left side, it's just -5. Her knee range of motion distal neurovascular examination was intact, and the Harris hip score was 33. So these are the preoperative X-rays of this patient. As we can appreciate, and you're aware of dysplastic hip, and this is Crow type 4 and Hartoflickidis type 4 dysplastic hip, in which we can appreciate that there is no acetabulum formation and just completed dysplastic hip, and both the femoral head has been dislocated superiorly and posteriorly. So these are the X-rays which was done with the traction to look for the muscle contraction. We can appreciate there's no much gain of the length we get with the traction views. So we got that for the proper preoperative planning and to look for the acetabular morphology, the CT scan of the pelvis was done to look for the proper acetabular morphology. These are the axial scans, cuts of the CT scan, in which if we go further, we will appreciate that both the femoral head has been dislocated and significantly quite posterior superior in direction. And we can also appreciate that the acetabular is completely dysplastic, and there is acetabulum, there is no true or the false acetabulum. The patient has been walking on it for past many years. You can also appreciate a similar finding in this cut. As we go further, we can appreciate that so let's move towards the 3D scans, 3D reconstruction images of the pelvis, in which we can appreciate that there is even the acetabulum has not been formed at all, and both the hip has been completely dislocated. So it's Crow type 4 and Hartoflickidis type 4. So what are the challenges that the surgeon should think of before going into the OR for this patient? That this is a young female who is 34-year-old, and she needs she has a very high functional demand. There is significant deficiency on the acetabular side. There is the limb length discrepancy, and we will also encounter significant muscle contractures for the reduction, and there is aberrant anatomy of the proximal femur. So this patient was planned for staged bilateral total hip replacement, and the first one was done on 20th of July 2018, and the second on 27th of July 2018. So these are the post-operative X-rays of after left total hip replacement. So the major concern with the total hip replacement arthroplasty is the containment and incorporation of the acetabular cup and the placement of the acetabular cup. In this patient, we specifically did one procedure which is known as a Contraindications, which is a controlled perforation of the medial wall of the acetabulum and medialization of the acetabular cup. So the medialization of the acetabular cup decreases the hip load and satisfactory superior lateral support of the component with the host bone and the bone graft. And the Contraindications has been well formed and known by in 2008 by Beckoning et al. And proved that every millimeter of lateral displacement of the acetabular cup relative to the ideal center rotation of the hip increases 0.7% load with every lateralization. So in this, we can appreciate that the adequate medialization of the acetabular cup has been done. The femoral shortening was done and fixed with the trochanteric plate. After this, the patient underwent the right total hip replacement, which was a stage after 5 days. And these are the post-operative X-rays in which you can see the same procedure. So at 2-year follow-up, the patient, post-operative, the patient was mobilizing with the walker, and about 8 to 12 weeks, she stopped using the walker and mobilizing without support. And at 2-year follow-up, when she followed up in the clinic, these are the post-operative X-rays, which you can appreciate that the osteotomy side has been completely healed. The hip has been well placed, and the Harris hip score at the follow-up was 78.5, which is a quite well improvement from 33 to 78.5. And at 3 months and 10 months follow-up, she's walking without support. So patient is completely pain-free and her HiRECIPE score is 80.5. So concluding the limb discrepancy, it was 68.5 on the left side and the 58 with 9.3. The tibial inclination has been gained and sublimous form, and femoral offset is bilaterally near or equally. So these are the videos of this patient in which we can appreciate that she has no difficulty in sitting and up and down this chair, and in which we can also see her walking. Her gait has been there is some lurch at the right side, however, but the patient is walking without support and she has no pain post-operatively. So I came across a version of orthopedics, a concept of dysplastic hip techniques for femoral head reconstruction, which has been published. And they said that the anterior, posterior, or lateral view of the preferred method of the treatment. So in this dimension, the Oncology was done. The dome of the cup is protruded beyond the collar line inside the pelvis. And the superior lateral part of the cup is uncovered with the bone, as you can appreciate in the post-operative X-rays. So thank you so much. If you guys have any questions. Thank you.
If no any question, then move towards the next case. I would like to invite the Dr. Sherbaz Khan, our Arthroplasty fellow, who will present his two cases. Dr. Sherbaz Khan.
Bismillahirrahmanirrahim. I am Dr. Sherbaz, Fellow Orthoplasty here at our Khan University Hospital, and I will be presenting a few cases of arthroplasty, and my supervisor is Dr. Masood Umar. So the first this is a first case, a 62 years lady, known case of diabetes, hypertension, depression. She had underwent high tibial osteotomy 20 years back for a medial compartment osteoarthritis grade 1. Presented to us with both knees pain. Her left knee pain was more than the right one for the last 2 years, which was progressive. And she had difficulty in climbing stairs, and her daily life activities were limited due to this pain. So on examination, there was a varus deformity over the right knee of about 5 degrees. But the left knee, there was no varus valgus deformity. Range of motion on both sides was acceptable from 0 to 140 on right and 0 to 120 degree on left side. There was joint tenderness, varus valgus stress test negative, and there was no flexion deformity. Patellofemoral tendon was there, and there was crepitus, but no effusion was there. So these are the clinical videos of the patient. वीडियो की मैंने किया तो है, इधर तो आ रही है. Changing the slide. Final. So here you can see patient has empelvic gait. So the range of motion. On left side from 0 to almost 120 degrees. So she has a good outcome after high tibial osteotomy. This is a 20 years follow-up of high tibial osteotomy. Then she developed knee pain for last 2 years. So these are the radiographs, AP, both knees, AP standing and the lateral views. There you can appreciate the medial compartment on the left side. The medial tibial plate is slightly elevated than the left one. The previous surgery implant joint line is joint space is reduced with subchondral sclerosis, and anteriorly you can appreciate there is patellofemoral involvement with osteophyte, and also you can appreciate the sagittal. The sagittal on sagittal or the lateral view, you can appreciate the posterior slope is reversed. So these are the issues after high tibial osteotomies, the coronal and the sagittal deformities after high tibial osteotomies. So it is grade 3 according to Kellgren-Lawrence classification. So this is the scanogram, AP standing. Here you can appreciate the mechanical axis from the center of the hip to center of the ankle. On left side, you can appreciate the line is passing through center of the knee, which is quite normal, but on left side, it is medial to the joint, mid of the knee, and there is no leg length discrepancy. So here you can appreciate this is the joint line, which is incongruent. This is the angle between the anatomical axis of the femur, anatomical axis of the tibia, which is about 4.9 degrees. That is quite normal. 5 degrees of valgus is there. And here you can appreciate the far left X-ray, the proximal medial anatomical axis of the proximal tibia, which is usually normally below 90, and usually it is 87. But here you can see it is 96.5 degrees, which is due to the closed osteotomy of the previous surgery. So the medial compartment is elevated, the lateral is depressed. So this is due to this, there is stretch over the MCL. Here you can see the lateral distal femoral anatomical angle, which is within normal limit. But here you can appreciate on the lateral view, the posterior slope is reversed, which is usually from 82 to 87 degrees. But in this case, it is reversed, it is more than 90 degrees. So this is the sagittal plane deformity. So this is our pre-operative planning for bony resections. For the tibia, the proximal tibial cut should be perpendicular to the anatomical, which is also mechanical axis of the tibia. So it should be perpendicular, the cut should be perpendicular to this anatomical axis. So for making it perpendicular to this anatomical axis, we have to resect this much of the bone, minimal bone resection over the lateral compartment, and more bone resection over the medial compartment. So about 7 mm of bone resection is required to make it perpendicular to the anatomical axis. And then for making a rectangular gap, we have to resect about 9 mm of the distal femur. So there is no patella baja or patella alta, and this is the valgus friction angle from the center of the hip to center of the knee, and from center of the knee, the anatomical axis. The angle between these two lines is called valgus correction angle, which is almost 5.6 degrees. So what are the technical issues after having high tibial osteotomy? The coronal and the sagittal plane deformities are there. The previous surgery incision, because the knee has blood supply from the medial aspect, more from the medial aspect. So parallel incision at the knee causes more ischemic skin, and the presence of hardware. To remove the hardware, you have to plan from which incision you have to remove, because multiple incision make the soft tissue more precarious for this ischemia. And then the soft tissue balancing, as I already said, the medial collateral ligament, it will usually stretched because of the elevated medial tibial plateau. So this was the pre-operative, intraoperative picture of the our planning for the surgery. So we use the standard medial parapatellar approach, and sorry. And you can appreciate this is the previous surgery incision, and this is our new surgery incision. So we did this incision, and the distance between this new incision and the previous incision, literature says it should be more than 8 centimeter. Though we tried to maintain the 8 centimeter, but at distal end it was not possible, because we had to remove the plate which was laterally from this. So we had to elevate the flap. So these are the technical issues, and then this is our bony resection. This is the medial, and this is the lateral. On medial side, we removed about 7 mm of the 6 mm of the bone, and the lateral side it was minimal, about 2 mm. So even after this very conservative bony resection, we had a large flexion extension gap, and then for that we had to use tibial wedge augments on medial and the lateral side, which were size of 6 mm, and we had to use tibial stem, as you know, to relieve the stress over the metaphyseal part of the tibia, and we also resurfaced the patella. So these are the post-operative, immediate post-operative X-rays of the patient. Here you can appreciate it is cemented, good cementation. There is no overhanging, or the size of the implant is proper. The wedges are here on lateral and medial. So it is about 6 mm of the wedges were used. So there is no notching. The alpha, beta, delta, and this gamma angles. The gamma angle is slightly increased, which seems the femoral component seems to be slightly in flexion, but the range of motion was quite good. And after replacing, we had a good insult salvati ratio. So this was the issue. Here you can appreciate the skin between the previous incision and our new incision. It is slightly necrosed and blistering of the skin. So even after having, because we had to raise the flap from here to here, and then this previous incision. So there should be more distance between to have a good blood supply. So the literature review, reduced rate of satisfactory result and increased difficulty in exposing the knee is due to presence of low-lying patella, which is usually after open wedge osteotomy. Because we had no issue of patella because the previous surgery was lateral closed wedge osteotomy. So varying degree of deformity, frontal and sagittal plane, bone loss, ligamentous imbalance, and the choice of approach in relation to presence of previous skin incision, lateral translation of the tibial epiphysis with alteration of the position of the medullary canal, which is usually seen in the open wedge osteotomies. So their recommendation was the skin thickness of the bone resection from the lateral region of the tibia must be very small to re-establish the anatomical position of the lateral articular line. And it helps to reduce the possibility of instability or the use of excessive tibial inserts, thick inserts. So in case of lateral closed wedge osteotomies, may sometimes require bone graft or metal augments. So this was the case of ours. To reduce mechanical stress on the metaphyseal region, it is advisable to use medullary stems. And in case of lateral translation of the tibial epiphysis, reduce the size of tibial component, moving it more medially using components with shorter pegs or custom-made prosthesis with more offset. And ligament instability in patient with valgus overcorrection. So Korokov method of plication of the MCL is advised for this. And they advise to perform ligamentous or soft tissue releases after the bony resections, not before than that. So high risk of revision in total knee arthroplasty after high tibial osteotomy. So the traditional, the use of traditional method to determine femoral component rotation is often misleading in these cases. And we usually use external rotation of the femoral component, but they suggest in cases of high tibial osteotomy, an internal rotation of femoral component may be required to have a good balance. So in summary, this is 20 years good outcome of a closed wedge osteotomy for a medial compartment osteoarthritis 20 years back. And a TK after H2A are technically demanding accurate preoperative planning, precise surgical techniques, and adequate distance between the previous incision and a new incision to avoid skin problems. So this is another case. A 64 years lady with she is a known case of hypertension, presented 1 year back with history of road traffic accident with trauma to her left shoulder. These are the injury films. At that time, you can appreciate the proximal humeral fracture. It is a 4-part fracture, and the bone quality is very osteoporotic with multiple fragments. So it is not reconstructible with any plate. So after discussion with the patient, we went for the reverse shoulder arthroplasty. So these are the immediate X-rays of the patient 1 year back, and these are the X-rays, recent X-rays. You can appreciate it is a cemented stem and non-cemented glenoid hemisphere. Inferiorly based, the base plate should be placed inferiorly to avoid the notching at the scapula. Usually, if it is high, this reverse shoulder concave surface of this impinges with the stabilium, this scapula if it is placed high. So this is video of the recent video of the patient. Good range of motion and a good functional outcome of the patient. She has no pain. So the reverse shoulder arthroplasty for proximal humeral fracture, a review article from current reviews in musculoskeletal medicine. So reverse shoulder arthroplasty versus hemiarthroplasty for proximal humeral fracture. So the revision in case of this hemiarthroplasty is more than this reverse shoulder. So reverse shoulder is more stable in cases of where the proximal humeral fracture, four-part fracture. So the revision is more in cases of hemiarthroplasties. These are the different articles. So the review article suggests more revision in cases of hemiarthroplasties. So where the indications, so physiological age more than 65, so unconstructible, highly displaced 3 or 4-part fracture of the proximal humerus, head split proximal humerus fracture, failed proximal humeral fractures, ORIF, symptomatic malunion, non-union, or failed hemiarthroplasty. These are the indications, and these are the contraindications for where there is deltoid deficiency, axillary nerve dysfunction, insufficient bone stock in the glenoid cavity, active shoulder infection, medically unwell patient, high demanding patient. You can't do this reverse shoulder in active patients, and the Charcot joint. So reverse shoulder arthroplasty is increasing in use for proximal humeral fracture as hemiarthroplasty decreases, and the open reduction internal fixation rate is still stable. Reverse shoulder arthroplasty is preferred treatment for 3 and 4-part fractures and head splitting fractures of the proximal humerus in physiologically older individual. Functional outcome score, range of motion satisfaction are superior when compared to other surgical treatments. The revision and the reoperation rate are significantly lower in hemiarthroplasty with benefits. Significantly improves functional outcome are reported, especially in the elderly patients. So the patient and the surgeon should be aware that while function will not be normal, it is generally adequate for low demanding population. So reverse shoulder arthroplasty is superior to plate fixation at 2 years for displaced humeral fractures in elderly patients. This is a review article in JBJS. So at 2 years follow-up, the data suggests advantage of reverse shoulder total shoulder arthroplasty over ORIF in treatment of displaced proximal humerus fractures in elderly patients. So because of the low revision in cases of this reverse shoulder hemiarthroplasty. Thank you.
Any question? Then move towards the next case.
Regarding first case, there are a couple of comments.
Yes, sir.
Question. You see, the decision was exactly we do it for primary to the lead.
Yes.
So if you could have given decision slightly on the midline or on the lateral side, or the with that decision probably you require less undermine of the skin, and you would achieve that picture around the skin. So much you will determine.
Yes.
You will be
Less skin. Yeah.
microvascular damage to the second, there is a thermal component was next position.
Slide. Yes, sir.
So what was the distal amount of resection which you could do from distal to
It was 9 mm, sir.
So what do you think? What was the reason of excessive flexion? So because proximal tibia the section was only 7, but the preoperatively which you showed of him that did not show any ligament next. So
Yes, there was no. Actually, after I think it was a stretch over the MCL because of the elevated medial tibial plateau, and when we resected that MCL become laxed. I think that was the issue of the more flexion and extension gap.
That's why this is one reason many people over the last 10, 15 years have looked at the literature of doing HPO, proximal tibial osteotomy. They have moved from closing leg osteotomy to proximal medial open leg osteotomy. So we deserve actually medial greater ligament on that side, and people who have a good up rate, do not have a good up rate, maybe you can take a piece of osteotomy from the fibular side and you can relate them depending on how much. With that, we will actually try to restore our plasma alignment and the subsequent complication of actually MCL stretching is minimized.
Thank you.
You mentioned about the comparison for from the sub. I understood that you mentioned about the results between reverse shoulder versus plateau. But what about the anatomical shoulder? If rotator function was good enough.
You are saying total shoulder arthroplasty?
Yes, anatomical shoulder.
Because after this 4-part fracture, the rotator cuff, which is attached to the greater tuberosity, it is gone, and in elderly patient it is already insufficient. So doing total shoulder arthroplasty, you can't do this range of motion after that. You have to do reverse shoulder arthroplasty to have a good range of motion where there is deficiency of rotator cuff. So in this patient, there was a deficiency of rotator cuff, and elderly patients, we usually encounter this deficiency of, and with 4-part fracture where the attachment is gone, you can't do a total shoulder arthroplasty. Yes, in where there is a sufficient rotator cuff function, you can do total shoulder arthroplasty.
No further question to move towards the next case. I am Dr. Rufinari. I am presenting the case, and my work is supervisor Dr. Beverage Harsh. I have a case of 68-year-old female. She is known case of rheumatoid arthritis, hypertension, and she is osteoporotic. And she was presented to us with a bilateral knee pain since 6 years, which restricted his daily routine activity. She is unable to squat and difficulty in ascent and descent of stairs. She used multiple conservative trials for her knee pain, like injections and pain medications and physiotherapy, but the symptoms are not improving. So on the examination, she has severe joint line tenderness, clear patellofemoral tenderness with crepitations, and her range of motion was 0 by 90 bilaterally. Her knee society score was 63 bilaterally and with a functional score of 40. So looking for the pre-operative knee bilateral AP view, you can appreciate that there is a decreased joint line surfaces and severe osteoporotic bone density, and along with their osteophytes and sclerotic margins are appreciable. On the lateral view and the scalenum view, you can appreciate that there is a severe patellofemoral arthritis along with the posterior osteophytes. On the lateral, you can appreciate it. So we counsel the patient and we did bilateral total knee replacement. These are our post-operative X-rays in which you can appreciate it. There is a normal alignment of the knee, well-fixed implant, and good cementing was present, and well appreciated joint space. These are the lateral view. You can appreciate it. There is no notching and no good cementations are present. So the post-op recovery was smooth. She was walking with the immobilizer and she walked clearly, but she has a history of fall. After the surgery, 2 weeks after the surgery, his tribal trauma is a twist hernia. So she was again presented to us with a left knee pain, and we did X-ray. In which is X-ray, you can appreciate it on the left knee. There is a increased slight malrotation of the implant, increased medial femoral condyle component, increased size of the medial femoral component. She has a severe pain, unable to move weight, and on the lateral view, you can appreciate it. There is a increased posterior femoral component, loosening of implant, and anterior notching can be appreciated. So as compared to the previous post-operative images to the after the images, we can appreciate it. There is a small rotation of implant with the prominences of medial epicondyle. On the lateral view, we can appreciate it from the previous post-operative view. There is a loosenings and overhanging of implant. So we did CT scan and we have a suspicion there is a periprostatic fracture. We did CT scan and the CT scan images shows there is a medial condyle fracture, which is comminuted. According to the Lois and Rodenbach classification, it is classified as type 3 with a fracture with component loosening. So in this stage, she is osteoporotic and she has a medial condyle, which is a comminuted fracture. We advise and we go for the revision knee with a rotating hinge implant. These are in intraoperative findings. There's a completely shattered medial condyle of the femur. However, medial MCL and LCLs are lax but attached to the sacrum. We did a rotating hinge implant. We also replaced the tibia as well. So, coming towards the periprostatic fracture about the total knee orthoplasty, because the distal femur periprostatic fractures are common about the total knee and reported to occur 1.8% of the patient after primary total knee replacement. Women and elderly patients with poor bone quality are at a greatest risk of these injuries. Additional risk factors included the steroid, rheumatoid arthritis, region 7Gs, neurological abnormalities are also included. So these are the proposed treatment algorithm for the femur periprostatic fractures. If distal femur fracture is well-fixed implant, non-displaced fracture, you can immobilize. If a displaced fracture, you open femur box, so you have to you can do retrograde nail. If a displaced fracture with a closed femur box and implant is well fixed, you can do with an open plate. And if the implant is unstable and if a good bone stock, then go for the division orthoplasty. If a poor bone stock, then myeloprosthesis and allograft prosthesis composites. So So on the conclusions, our case, she is severely osteoporotic. She has a history of trauma. She has shattered middle epicondyle, which is non-reconstructible. So we have to go for the megaprosthesis. So in conclusion, in post-operative patients such as very highly special osteoporotic with poor bone quality, we have to immobilize and protective weight bearing after the post-total knee arthroplasty in these patients. Thank you. Any questions? If not any questions, we move toward the next case. I would like to invite Dr. Akil Ahmed, Year 4 resident orthopedics. He will be presenting the case of revision total hip replacement.
Assalamu alaikum. My name is Dr. Akil and I'm final year resident. So today I'm going to present a case. So basically this is a bit challenging case. We want opinion of the house on this case. So basically this is a patient is 89-year-old lady. Known case of hypertension, diabetes mellitus, Parkinson's disease, status post right total hip replacement in 2015 and left hemiarthroplasty 12 years ago. She has history of right hip dislocation last year 2 times. That was reduced by closed reduction methods under sedation, and both procedures were done outside AKUH. So this was 3rd time location when she presented to us in ER with history of pain in the right groin region, and there was no history of trauma. On X-rays, we found that there is a dislocation of the femoral component, that is anterosuperior, and closed reduction was tried around 2 to 3 times, and it was reducible, but it was unstable. So it was easily, it was dislocating very easily. So we did CT scan. On CT scan, you can appreciate here that there is a dislocation of the femoral component that is anterosuperior, that is clearly visible in other views. In this patient, treatment options were resection, arthroplasty, and revision total hip replacement. As the patient was had multiple comorbidities, most important was Parkinson's disease. So we counseled the patient that these are the 2 options, and resection arthroplasty has its own merits and demerits, and revision has its own. So patient had family in USA, so they took advice from some of the doctor in USA. So they took advice there, and they opted for revision total hip replacement. As they were thinking that with resection the hip will be unstable, and the patient already was had Parkinson's disease, so they opted for this option. So intraoperatively, we found that there was undisplaced fracture of the anterior wall along the roof region, and there was anterosuperior dislocation, cemented acetabular and femoral component, excessive femoral component anteversion, and excessive acetabular component anteversion as well. So in this patient, our planning was to do extended trochanteric osteotomy. But while extracting, as the both components were cemented, so while extracting the cement, we underwent the femoral component. There was fracture around the pertrochanteric region. So This is the video showing that
अब इसे देखें आहिस्ता आहिस्ता
the femoral component has excessive antiversion.
ये जब आप
Greater
कान
drop
न्यूट्रल पोजीशन में आप जमीन पे
should
रखते हैं
point
तो ये पीछे से
in this
हालांकि ये जमीन पे रखें
laterally, but it was pointing medially, so there was excessive antiversion.
इंट्रोवर्टेड है
We revised the vestibular component. First, our plan was to revise the vestibular component only. Once we revised the vestibular component with triplaned cup, we found there was limb lengthening. So we then plan for revision of the femoral component as well. So this video is representing that there was excessive femoral antiversion.
I think you are showing the wrong video. You're not showing the first video.
This is the first video, sorry.
The wrong video. The wrong direction. Second, the sequence of procedures you are not telling right. This is the paper screen. Let me explain if I can.
Yes, sir.
See, our plan was to do a minimum thing so that we can.
अब ये देखें ये एंटीवर्टेड है अब इसकी हिप पे जाके फोकस करो हाँ, हिप पे फोकस करो ये पोजीशन है और टांग को भी देखें ये पोजीशन
हिप के अंदर अंदर अंदर
ये देखना
Once actually we expected that the World Cup will move and then revise the World Cup in the triplan.
ये स्टेबल तो है इस वक्त ये पोस्टीरियर के लिए तो नहीं जा रहा
लेकिन एंटीरियर के लिए देख सकते हैं
अच्छा हम देखें इंटीरियर भी नहीं जाएगा डुअल मोबिलिटी है ना
सही
फिर बता देते
चलो हटो
During removal of femoral component, once the proximal half of cement was removed, we had a lot of difficulty removing the cement from the inside. And here I was thinking of doing a PTO extended Telecast osteotomy, but in the meantime, when he was actually assistant who presented, he just did an internal rotation in the bone crack. He had a spiral sort of a fracture, just like it was mimicking like it is a PTO extended Telecast osteotomy. So then we had to do removal of all the bone cement from the medullary cavity. And now he can show you, look at these two actually osteotome. One osteotome is toward the tip of greater septum, along the length of neck, and other osteotome is posteriorly. So you can see how much antiversion that person had. This is excessive antiversion of the component. That's why over the last 15-20 years, I have been saying that doing a cemented total hip is, if it is not done by an expert surgeon, because once cement is fixed, whatsoever position you are, it will be fixed in that position. So you cannot go back and revise it. So in case of a cemented prosthesis, you can immediately actually correct your antiversion, especially when you are doing with an anterior approach. This was done with an anterior approach, with the both cup as well as the femoral component, with a lot of antiversion, anterior, and there was anterior dislocation. And she had a lot of difficulty in walking, especially she used to do walker, hardly walked at home over the last 5 years. And this year she had a 2 dislocation. That's why the family wanted to need to resolve this issue. So that's what we
Yes. So we use these this implant with the specific parameters: triplan cup of size 51, cup liner of 28 into 51 mm diameter, femoral head, stem, S2 body, and we use trochanteric plate, 13 hole, and cable slit. So these are the post-operative images. You can appreciate that the abduction angle is very well maintained, and femoral component is filling the canal. Because of pertrochanteric fracture, our plan was to fix it with cable because the bone was osteoporotic. So we had to use this 13-hole trochanteric plate that was stabilized proximally and distally with the screws, and we used cable wires. So this is the lateral view. So post-operative, there was both clinical and there was no LLD clinically, and around 2 on radiological. So this is the abduction angle around 43.6 degree, which is in normal range. And initially there was abduction of around 35 degree. Now post-operatively, sorry, anteversion, it is around 9.6 degree. So these are the images. So post-operatively, patient was mobilized with the help of walker, toe touch, weight bearing, and so this is the case. So any opinion on this case?
Any questions regarding the case? If there is no question, we end the sections and we start our foot and ankles session with the presentations. I'm Dr. Pilali. I'm going to present my foot and ankle cases, and my work is supervisor Dr. Ismana Alu and Dr. Kashmir. I'm presenting a case of 17-year-old boy. He was presented to us with a 6 weeks history after a high velocity RD, and she underwent a spinal fixation of L4, L5 vertebral fractures, left radius ulnar open reduction and ulnar fixation, and left proximal femoral nail for intratrochanteric fracture, along with K-wire for less front injury, which all procedures were done outside the AKUH, and was presented to us with a left foot swell. These are our initial foot X-rays, in which you can appreciate there is a comminuted and this front injuries with the displacement of the second and third metacarpals and shattered medial and middle column of the foot. In the lateral view, you can also appreciate there is a dorsal dislocation of the both medial column. So this initial K-wire was done outside the AKUH, and you can appreciate it this poorly hold the fracture. We did CT scan with 3D reconstruction, in which you can appreciate it there is still dorsal dislocation of the medial column. These are the 3D images, and we can appreciate it there is fractures of the middle and medial column both way, which is not held by the K-wire. So in such type of the case, what can be done? What can we will do? Any idea for the audience? The patient is presented in such type of a foot with foot swelling, and 6 weeks after the injury with a K-wire fixation. No any idea? So in this type of patient, we have to achieve the plantigrade foot. We have to achieve the medial column and middle arch. So we have to remove the all K-wires. We did open reduction and fusion of the first medial column with the plate, and we did open reduction and internal fixation of the middle and medial column. We fixed both columns as well. These are the initial post-operative X-rays, and patient was kept on non-weight bearing with the help of the long short length cast. These are lateral radiograph, and we can appreciate that there is a well fixed fixation of the columns, and we achieve the arch, medial arch. These are also 5th-month follow-up X-rays, which you can hold the fractures and fractures healed almost. These are 5th-month follow-up video. This slide linking you can appreciate it because of the spinal injury. the summary, patient was presented as late, and she has polytrauma fracture with a complex foot injury, and it is technically cell injury because it has to be, in these cases, we have to do the special consideration of the soft tissue management. Thank you. Any questions? Okay. Yes.
Can you please elaborate more on the usual way of fixing this fracture? Something special has been done. So you need to highlight that also, for at least for the residents. What difference you made in fixation?
So we go plantar, we reduce the plantar plate and we use plantar fixation, for the approach of the patients and approach management for the soft tissue. And we have to hold the fracture and we use plantar plate in this fixation.
So that is what I wanted to explain, because this is not the usual mode of fixation. Was something new for me. So very good.
So can you go for the AKUH? Dr. Ismail, in this case, so as you can see that the lateral column is still dislocated. But the good thing is, medial column 5-degree motion, middle column 0 motion, lateral column 15 to 20-degree motion. So we did 2 incisions, so we were not brave enough to use a third incision to reduce 6-week-old fixed dislocation. So what we do, we did, as she already said, that we maintain the parabola. We maintain the middle and the medial column integrity. Lateral column to वैसे ही mobile है. तो कोई problem होगा नहीं अगर बाद में कभी होता भी है. Now, माशाल्लाह बन गया down the line. So we can go section after Arthroplasty of the fifth metatarsal base if needed. If not, you can continue to live naturally. So initially, अगर आप सही डाल दिया करें, case में आप देखें, all the KYs were just outside. They were not holding anything. That's why 6 weeks down the line, the foot was still ballooned. Because most of आपको 2-3 हफ्तों में नहीं अच्छा आ रहा, तो that means there is something wrong with the KYs. You have to be very, तो उसी वक्त अच्छे KYs डालना है.
Pre-operative X-ray KYs. So with one set, we cannot discard the KY totally and go to this system, and there is no excuse that you don't have this system at your hospital. Still, KY, I'm sure Dr. Fashmi will also agree with me that most of the list rank in our time were fixed with KY, but then you have to use them properly. Adequate fixation. So one KY is not holding the distal fragment, this was one. And you are not to, even sometimes you need to go up to talus. You need to fix them properly. So adequate fixation with KY most of the time will solve your problem.
Thank you for the remarks. If no other further question, I would like to move the next case. Next case is again the foot and ankle category, same presenter and same supervisors. So the initial history is a 20-year-old gentleman. She was presented to us in ER with a history of RDA after riding the bike. These are the clinical pictures. You can appreciate that there is an open injury on the middle of the first metatarsus, exposing the joints. These are the preoperative X-rays. So depending upon the open wound and this preoperative X-rays, what are the management, initial managements, any residents, any opinion? Just the opinion, Dr. Saddam. Thank you. So in this preoperative X-rays, you can appreciate it, the first metatarsal joint fracture dislocation with multiple most of the comminution and the loss of the metatarsal height as well. So initially we did debridement as a routine protocol. We did thorough debridement. We did culture. We sent cultures. And the culture shows the Enterococcus specialties and few colonies of bacillus specialties, and we put on her antibiotics. But in this case, we have to, along with the antibiotics in open injuries, we have to stabilize the fractures and we have to maintain the length of the metatarsal as well. So we put AKUH and we put the antibiotic cement block for the resolution of infection, as well as for the maintenance of height of the metatarsal. So after the 12 months, he was managed. He had managed with the IV antibiotics, IV and oral antibiotics both. After the resolution of the same infections, we plan for two medial column fusions. Here are the initial post-operative images in which we can appreciate it. We again use the plantar plate for the medial column fusion. And it's well fixed implant and well fixed position. He was kept on the in the short leg back slab and on midway for the 6 weeks. After that, he was starting midway. He was post-operative X-rays after 5th month. You can appreciate it. There is the fusion site as well healed. There is no swelling. And in this way, we treat the infection and we achieve the plantigrade foot of the patient and we achieve the first metatarsal height as well. These are our videos. We can appreciate it. We can stand and say plantigrade achievement was done. He was walking pain-free. Thank you. Any questions? Yes.
So first experience. So for the postgraduates, what will happen if you only do debridement and infection settling? After this debrid, we are working in a specialty areas. We have got arthroscopies in Pakistan, Karachi, where we are seeing cases of dunya mein. So in the exoscope now you have to see like that. So what is the problem? What will be the problem here? If you do this, you both nikalo, sab kuch kar do, what will happen? He's a young guy. So basically the medial uniform, they all have got attachment of the Gallus anterior, basically the Gallus posterior. So आज को रखने के chances बहुत हैं. So you have to make sure the patient should not be in pain 5 years down the line. He will visit you. He's not an 80-year-old guy. So you have to make sure. So we just did debridement, as you can see, the wires are in the Liston joint. The Liston joint was gone. So after that, the wires are in the Liston joint. Actually, you have to put a wire from the video to the base of the second metatarsal, but वो fracture का तो didn't do it. So हमने इसे blank maintain करने के लिए parts और transverse wires from the first to the second metatarsal, ताकि हर चीज अपनी stable रहे. मैं 6 आठ के बाद फिर जाऊँ तो मुझे ना खींचना पड़ेगा कुछ. Already it is a bit distracted. The parabola first metatarsal है, fifth metatarsal है, calcaneal in the tripod. Imagine a camera on a tripod with only two limbs. You cannot have a good picture. You have to keep this in mind, and then फिर हमें जब ये antibiotic का सिंगल निकाला तो वो masculine technique है कि membrane बन जाती है. You just put graft in that thing and just came out and put a planter plate. So it makes your life easier if you do it right the first time. So that is the take-home thing for you guys to see here. Thank you.
So if no further comment, we ended the foot and ankle section and we start our hand and wrist and microsurgery section. I would like to invite Dr. Mohammed Yunus Durrani, a resident, a year 2 orthopedic resident.
You need to release the compartment. You used to do so do you used to do the release of this compartment whenever the compartment is in the foot, or always do some elevation?
We advise, we initially, our protocol for advice limb elevation and icing for the patient. And first of all, in this type of injuries, we allow, if there is a massive swelling, we put on limb.
Compartment, you know, we go for the release of this compartment.
Yes. Yeah.
So how to release the foot or this release the foot compartment?
Just 2 incisions on a dorsal aspect from the second metatarsals and the fourth metatarsals, and we release the compartment.
Only release the 2 incisions on foot. So with 2 incisions, you only release the intra. How to release the other ones? How do you release the superficial deep in the foot? How to release the calcaneal compartment?
So depending.
At least you need to have 3 incisions. 2 dorsal, 1 in medial. So 1 medial will release superficial, after that will release the calcaneal.
Yes.
So whenever you compartment system is there in the foot, so one will release it. Because there will increase the pressure and come out, take to some deformity. You will take the bone, but then muscle will get necros and you will have line and some other deformity. So always consider for that whenever you have some extension in the
Yes.
Yes. So, Bismillahirrahmanirrahim. My name is Dr. Mohammed Yunus. I'm resident here at Khan University Hospital. I'll be presenting 2 cases of flexor tendon injuries which came to our OPD. So, case 1. She's a 35-year-old lady, gynecologist by profession. She came to us in the OPD with complaints of knife cut injury at home, and she had a scar on the borderline second zone of the hand. Borderline second zone of the hand, you can see the scar, and you can also see that she is able to flex all the fingers except she is unable to flex the index finger. And a scar picture you can see on the top left. Here is the scar and the zone 2, and these are the zones of the hand. So we examined her, and this is the clinical picture preoperatively. We explored her zone 2, and we saw that the flexor tendons were ruptured, cut, and we did a cruciate repair On examination, also the sensations were intact, digital vessels were intact, and we did a 4-strand cruciate repair and a epitendinous sutures, which is shown in this diagram, in the bottom left diagram. This is the immediate post-operative picture. This injury was actually 2 weeks old. That's why you see the scar is healed. So initially, we put her on Kleinert regime, which was active motion, and from day 0 to day 3, we put her in a splint with 20-degree flexion of the 50-degree flexion of the MCP joint and 20-degree flexion of the Rix joint. And after that, we were planned, and we put in some elastic traction so that she can start active range of motion. And these can be started with using these dress hooks over the nails, which can be attached to the nails with the adhesives. Later on, she presented to us in the clinic after 2 weeks. She said that I don't want this splint, I don't want these elastic range of motion exercises. I just want to get free from the splint. So we shift her to the Indiana regime at week 4, and we removed the splint and we started her on active range of motion exercises in the week 2. And these are this is the video of her about 2 months from the surgery, and you can see in the sagittal plane that she is able to actively flex her DIP, PIP, and MCP joints. So, case 2. This is a 20-year-old labor. He was working in the field when a heavy object fell on his hand. You can see the injuries on the volar aspect of the hand, and you can see crush injuries. We did the X-rays. X-rays were fine. There were no bony injury. And when we examined him under local anesthesia, you can see that he's able to flex PIP, DIP on the index finger, but he's unable to flex the PIP or DIP on the middle finger. But the lumbricals are intact, and all the other fingers were intact. So it was a flexor tendon injury on the middle finger. So initially, what we did was we did wound debridement. And started him on range of motion exercises until the wound was healed. Once we examined him after about 2 weeks in the clinic, but he developed a flexion deformity at the DIP, as you can see in the diagram. So we moved on to exploring his hand, and we explored his hand. As you can see the operative picture, you can see that A4 pulley was disrupted. A2 pulley was intact, and the volar plate was disrupted. So during the surgery, what we did was we constructed the A4 pulley with the FDS tendon. We used this tendon to put in a graft, and we put the graft distally, we attached it to the stump of FDP, and proximally we attached it to the palmar draft, and we attached it with this technique, which you can see, palmar draft technique. And we constructed we also advanced the volar plate. Since we advanced the volar plate and made the volar plate, so we put in a K-wire in the middle finger, and the K-wire was taken out after 2 weeks. So once this K-wire, so initially we started him on the immobilization regime, and which was kept in a cast. And later on, after 2 weeks, we took the K-wire out in the clinic, and we started him. We still had him on immobilization regime, but he came and he said that he does not want any immobilization because he had to go back to the work. So we shifted the regime to Kleinert regime, and we started off with hourly active extensions. And then he said that he's unable to do these exercises also, and he wanted to resume his work because he had some financial constraints. So we shifted him on Indiana regime, which was early active motion, and we started him with active IP extension flexion exercises. So this is the post-operative picture of him, and this is the video of him after about 6 months of the repair. As you can see that he's able to flex the MCP joint and PIP joint, but at the DIP joint there is a flexion deformity. But he was able to cope up with this work. So discussion, just a few slides about the flexor tendon rehab. Your rehabilitation will always depend upon the technique of repair which you have done. One basic thing whenever you do a tendon graft repair, there is always, once you have sutured it, whatever technique have you used, the cell would migrate because the inflammatory cells would come in at that place, and the fibroblast and the collagen would migrate away. And that is why when there was a study about the suture tensions, you can see that if you use 2-strand sutures, 4-strand sutures, or 6-strand sutures, the power will decrease, the tension would decrease in the first week and would again regain in the second week, because after day 14 the collagen would come in and deposit at the suture side. So you need to be careful about this. So no very strengthening exercises until day 14. And in this you can see that 2-strand sutures is weaker than the 4-strand or 6-strand. So it is better if someone is using a 2-strand suture, it is recommended not to start the active range of motion exercises. So we always go for at least a 4-strand suture technique, so that if the patient wants, due to his duties or some other things, he can start off with active range of motion also. Tendon remodeling would take place similarly, that if you start early, motion would result in fewer adhesions, smoother gliding surfaces, stimulate intrinsic healing, and mobilization would improve ultimate range of motion, DNA content, and tendon nutrition, and rate of healing. So rehabilitate, just a few slides about the rehabilitation programs. There are 3 main regimes. One is the immobilization regime, the passive motion, and the active motion. So immobilization regime would always be there if you have severe injuries, for example, bony injuries or a volar plate injuries or something like that, as we have done in the case 2, which I have presented. So in the immobilization regime, would put him in a cast about 3 to 4 weeks, and then DC cast at 4 weeks, and start splint and start passive exercises. Similarly, Duren-Hauser regime is basically a passive motion regime, where in day 0 to 3 it would be in a splint and at wrist at 20-degree flexion, MCP joint at 50-degree flexion, and then 0 to 4 weeks then hourly exercises. The only downside of this regime is that the patient has to come almost daily for the first week and second week to the physiotherapy department. So it would be a financial constraint. As you can see, these are the few exercises the physiotherapist would make him do during this phase, because it is the only passive motion. We only allow passive motion. The physiotherapist can only do it until he understands what has to be done, and then he can move on to this regime at home. So this is one downside of this regime. When you move on to the Kleinert regime, which is the active motion regime, then you can put in some elastic active resistance, which can be put in with a dress hook, which you can see on the bottom diagram. And in this you can start off early active extension at the week 4, and you can even start it early as guided by your fixation or by your suturing techniques or your strength of the graft. Finally, the Indiana regime, which is early active motion. In this early active motion, the wrist can also be extended. In the rest of them, the wrist is usually flexed at 20 degrees, but in this, wrist can be extended and active motion can be started early. Thank you. If there is any question, you can ask.
Good presentation, Dr. Yunus. Any question from the audience? Next, we start our result section. I would like to invite the Dr. Ziad Ali, our R4 resident, to present the case.
Assalamu alaikum. My name is Dr. Ziad Ali. I'm Year 4 resident in orthopedics at Aga Khan Hospital. So I'll be presenting a case of management of segmental bone loss in tibia. My work is supervised by Dr. Yasir Mohib and Dr. Harun Rashid. So my patient was a 35-year-old gentleman, tile factory worker, functional class 1 with no prior comorbid. He presented to us in emergency department with industrial injury, crushing injury to the right leg on 24th April 2019, and after secondary to the fall of a heavy object. So this is the clinical picture of the right leg showing 11 into 5 centimeter wound onto the middle aspect of the right proximal half of the right leg, in which the fractured bone, tibial bone is extruded, and also stated there is crushing injury of the extending crushing injury up to the mid of right leg. The fracture bones are visible that are devoid of any soft tissue cover. So these are the preoperative radiographs that were done, which showing the comminuted fracture of the right tibia extending from the metaphysio diaphyseal junction up to the mid of tibial diaphysis. And the bone fragment is can be seen that is displaced medially. So what are the treatment options in this case? Any comment? So there are 3 widely used procedure in such cases: dissection osteogenesis with Lazarov, vascularized tubular graft, and a muscular technique. So this is the article which is clearly showing that the most commonly used method for limb salvage of treating full circumferential segmental bone loss or bone transpose use of vascularized tubular autografts and induced membrane method. So after thorough discussion with the family and the patient regarding pros and cons of different these 3 different procedures, the patient opted for Lazarov fixator, considering that the patient do not want to proceed for vascularized fibular graft because there might be there is associated morbidity of the contralateral limb, and the induced membrane, obviously it requires larger bone grafts considering this injury. So this was the procedure we performed. These are the immediate post-operative radiographs in which you can see we performed Lazarov fixation, and the bone, after thorough debridement and removal of the dead bone, tetrafocal frame was applied, and these are the 1 month radiographs, 1 month down the line radiographs. You can see this is the dummy ring and the proximal ring, and it is called tetrafocal because there is compression at this between these 2 rings, and we performed 3 osteotomies between the 2nd and the 3rd and the 3rd and the 4th and the 4th and the 5th, and with these we performed the dissection. So these rings were fixed with the 2 wires and 1 shanks in the proximal, while the dummy ring was just for the support without there was no bony support with the dummy ring. And similarly in the other last the 2nd and the 3rd and the 4th ring, 3rd, 4th and 5th ring, it was stabilized with 2 wires and shank screws, and additionally we applied another ring at the ankle region, which with 3 shank screws it was fixed. So this is the 6 months radiographs, follow-up radiographs, in which you can see we performed dissection And here, the one of the proximal osteotomy side, the dissection was stopped because of the wound issues, and we continued dissection on the second and the third osteotomy side, while compression at the between the proximal two rings. Additionally, after 8 months, we performed in January 2020, we performed fibular osteotomies, and with that we medialized the fibula in order to further strengthen our construct. And at the same time, we had some at the proximal docking side, there was skin skin puckering, and due to which we excised that skin, and we did acute docking at the proximal side. This is so this is the 1 year after removal of the Lizarov, and this is almost 1.5 years down the line. Radiographs in which you can see that the tibial bone is fully reconstructed in the AP as well as in the lateral radiograph. So few measurements, post-op measurements were done, in which the proximal medial posterior tibial angle was drawn, which is normally 77 to 84 degree. Our is in the 84.4, which is the normal limit. Similarly, in the AP radiographs, the medial proximal tibial angle, which the normal reference range is 87 to 92 degree, and our is 90 degree. So this is the video. This is the video sent by a patient yesterday. He is walking without any support and is pain-free. So multi-level defect fragment lengthening could provide sufficient bone formation and reduction of the total osteosynthesis time in one stage as compared to traditional Lizarov bone transport. This is an article in support of this long bone reconstruction using multi-level lengthening of bone defect fragments. Similarly, trifocal versus bifocal bone transport in treatment of long segmental tibial bone defects, which they concluded that the trifocal transport can significantly reduce the treatment time and number of additional surgical procedures. Tetrafocal bone transport, as in our case of the tibia with circular external fixator, is the case report that was published, in which they performed the dissection at the two different sites, retrograde as well as in the antegrade patient. But in our case, because of the distal bone, we performed retrograde dissection. So this was the case. Any comments? Um, 1 mm daily. So through all the osteotomy sites, we perform 3 mm. Initially 3 mm dissection was done per day, because at one osteotomy site we perform 1 mm, and the other side we perform 1 mm. The third osteotomy didn't work for us, so we performed 2 mm daily dissection.
In this case, there were some issues. Initially, when you perform the dissection, the patient's limb might experience some edema, and there is some swelling you can observe, and it's still shining skin was there. At that time, you have to intervene. For a few days, you have to slow down the rate of dissection. There is encounter this problem, the pain will settle down, and then we can continue with later. Swelling and other things settle down. At the proximal absorbing site, when we perform the dissection at the rate of 3 millimeters, there was some more indications that is the most. That's why we have to the same, and immediately after the position is in 2 months, we get rid of the same. Left surgery process. No left surgery was done in that case. When we transported, only then when we get all we have to remove. So there was need to remove all the from the calcium and all the kind of this is not a thing. So they will not there in some parts of the see, this is on the flexure side. The segment that is terminated part, that is coming out, that is more likely to be dead. Instead, you have good segment of the bone that you can preserve and you can put a one ring around and compress it, and only you can transport that and you make other osteotomies as well. So that was another one. So you see that bone is also dead. Actually, the piece that was free, which was taken out in this year, but the piece that is visible on the left hand side, initially we thought we could save that piece. We also it is divided for the pedestrian. But to confirm operatively, we performed a small drill hole, and there was no bleeding that was encountered. If we leave that hole, we definitely have to come again. That's why we at that time we decided to remove that. So Africa side was not. That's why we also remove it.
Approximate slab in emergency surgery was like 5 to 10 per year. More than that, let us say. Now it is 1 or 2 significantly reduced of tissue problem with this case. Actually, black dressing for promoting granulation tissue not recommended in the estimate, particularly hand and tibia. But yes, literature review people are now coming that even with the wound closure, if you apply back dressing which are available with certain design, so suture removal time decreased from 10 to 5 days. There are more and more indication for back. Here we don't use them. We don't want scar.
But in this particular case, when we remove this bone fragment, the skin is tend to be approximately. Later on with the transport, there are some issues which can be tested, and but in this case, it doesn't require any problems with the coverage.
Thank you.
Fibular Osteotomy without even segment transport does add in fracture. So we are doing this now. The non-unions with intact fibula without fibular osteotomy and with fibular osteotomy. So what is the difference between these two in terms of index?
If no other further question, towards the next session. As our spine surgeon is busy in surgery, he will join after shortly, and then his cases were present. Our second session will not be presented today, as our four surgeons as some emergency at home, he will not we will start with the trauma section. The next presenter is Dr. Priyanka.
Assalamualaikum. My name is Dr. Akir Ahmed, and I'm going to present a case of DHS. My work is supervised by Dr. Masood. So this is a case of a 25-year-old gentleman, known case of diabetes mellitus, hypertension, community ambulant. He has history of DCS for IT fracture on 17th June 2021, following ground level fall. Patient was started after this procedure, after 2 months after this procedure, partial weight bearing with walker, but he has pain in the right groin region since he started to bear weight, and progressively he was unable to bear weight. So these are the initial X-rays, which both X-rays and surgery was done outside AKUH. On this AP view of the pelvis, you can appreciate that there is a fracture of the right enterotrochanteric region, and this was fixed with this dynamic condylar screw. In this particular fixation, you can appreciate that the fixation is done in slightly varus as compared to the normal hip. Neck shaft angle is 123 degrees. This is 2 month post-op follow-up of the DCS. It is progressively going into varus, and subsequently this is the X-ray 4 month post-op. You can appreciate that there is a fracture, there is breakage of the distal 3 screws and almost 90-degree neck shaft angle. So in this case, as the patient was old age, we had 2 options: either to revise the osteosynthesis or to go for replacement surgery. So we counseled both treatment options to the patient. He opted for the osteosynthesis. So we did removal of the DCS implant and did open detection internal fixation with the DHS, and we also placed BMP on 6th November 2021. These are the immediate post-op images, AP view of the pelvis. We did not open the medial side of the fracture, and just fixation was done on traction table. We increased the neck shaft angle and passed the guide wire in the center of the head, both AP and lateral views, and fixed this fracture with the DHS plate. We did not remove these broken screws, and we placed the BMP both at the previous hole and at the fracture site as well. Post-operatively, patient was subsequently started on weight bearing. These are the X-rays 8-week post-op. You can appreciate that there is some callus formation. So this is the 3-month post-op follow-up. Very good progress in callus formation. This is the 5-month follow-up. So in this, this is the last X-ray. On this X-ray, you can see that neck shaft angle is 137 degree, slightly more as compared to the opposite side. And lateral view, you can appreciate that the defect on the medial side at the calcar region is almost filled with the callus. So so initially there was 123 degree neck shaft angle, which we improved to 137 degrees. And these are the post-op images on the recent follow-up. Well-healed scar mark, and patient was able to sit on the ground. He has advanced knee osteoarthritis, so he was not able to bend his knees fully. These are the images of the knee X-rays. This is the video of his gait. So this some back is maybe because of the knee osteoarthritis. He was able to walk without any support. So this is another video.
सर ऊपर
So he was able to do SLR.
कोई दर्द तो नहीं है? Patient has no pain. सीने पे रखें. अच्छा. घुटना मोड़ के दिखाइए. ठीक. सीधा करें.
So basically, this is a slide showing that there were some technical challenges. There was osteoporotic bone and anatomy was not restored. Probably there was also improper implant choice at initial surgery. We had two options: limb salvage with revision, arthroplasty. Patient opted for hip plate osteosynthesis, and it was successful, fortunately. So this is the review article showing recently published in 2020, showing the treatment options in the failed intertrough fracture. So in this article, the author explains that patient physiological age, functional level, life expectancy, non-union anatomic site fracture pattern, bone quality, bone stock, and any arthritis in the joint. These things should be kept in mind to go for the appropriate treatment. So for plate osteosynthesis, we have option of intramedullary nail or extramedullary devices like DHS. And for conversion arthroplasty, we have option of total hip replacement, PFR, and hemiarthroplasty. So these are some surgical techniques that he explained. So in conclusion, salvage of the failed internal fixation of the intertrochanteric fracture with properly selected implant and profound technique can lead to formulation of valuable surgical strategies, provide patients with satisfactory clinical outcomes. Thank you. Any comments or questions? Kind of.
Next, we start from our tumor section. I would like to invite Dr. Mali Sahib, our co-resident, and will present the case.
मेरी नहीं करेगी मुझे करने दो मुझे करने दो यही करना बहुत पहले से की सेपरेट करने बहुत पहले से नहीं करा लो किसी में हमारे हमारे कुछ प्रेजेंटेशन आ गई मुझे करने दो प्लीज बाद में डिस्कशन कर रहा हूँ। किसी में हमारा भी है नहीं पड़ेगी किसी को चला दो निकालो जानते हैं कितनी वीडियो करेंगे हम मार के स्टार्ट कर देते मैं यूएसबी में देता हूँ किसी की है वो स्टार्ट कर दो ना अभी जी तो पीछे है वो कर लो जी किसकी है डाउनलोड कर जाओ किसकी है
Sorry for the technical issues. So I'll start with. I'm Dr. Filari again, and I'm presenting a case of recurrent GCD with a 10 years follow-up. My work is supervised by Dr. Masuduma. So coming from the history of patient, she is 28-year-old lady diagnosed with a case of left proximal tibia joint cell tumor, and she was presented to us with a pain left leg and left knee with a 1 month presentation with difficulty in walking and weight bearing on the left lower leg 1 month ago. She has multiple surgeries and she has a very past surgical history, including biopsy, curettage, bone graft of the left proximal tibia lesion in 2006. And she had curettage bone cementing of the same lesion in 2008, and she again developed diagnosis as recurrence. She also has a chest mass with left upper lesion, which she underwent VATS associated with unithoracotomy in 2011. Now she was presented to us 10 years back with a recurrence of the same lesion. At that time on the examination, 10 centimeter linear scar mark of the anterolateral aspect of the left tibia, which is a diffuse swelling of the left proximal left, infusion of the left knee, and it is tender. Range of motion is 20 to 120 feet, and there is a linear discrepancy of 3 centimeters. These are our clinical images. These are scar mark, which is not completely appreciated. These are initial presentation of X-rays, in which we can appreciate there is a 9 centimeter of the lesion in with cement or involving the joint, which shows the recencies, and involving the intraarticular extension as well. We did scanograph, and in which we can appreciate there is a shortening of the tibia and again discrepancy of the 3 centimeter. In this case, it's a Fibonacci grade 3 intraarticular infection, recurrence of the disease. We have to go for the wide margin excision and reconstruction of the tibia as well, with the help of the prosthesis. These are the initial surgical scar, and this was one of the surgical scar marks. And there is a patellar tendon. So this is the tumor involving the whole knee joint, whole tibia, proximal tibia, and this is the clinical intraoperative picture. We did wide margin excisions, and we have the tibial loss, after the wide margin excision. 10.5 centimeter bone cuts along with the left proximal tibia, and we have to cut along with the popliteus muscle with the overlying skin and subcutaneous tissue will sacrifice proximal distal deep margins are sent for the frozen sections which were negative for the malignancy except for subcutaneous medial near the distal margin. These are the specimen radiographs. So after the wide margin excision, we reconstruct the joint with the help of the mega processes. These are the intraoperative picture of mega processes. These are new pictures and bone closure. So this is the initial phase of this post-operative images in which you can appreciate well-lined implant along with good cementing. Patient was walked with full weight bearing ambulation and his post-op curve is smooth. We for the ankle range of motion and knee range of motion exercises, and she was kept on training. These are again the initial phase of post-op image. Then again she came at 5th month follow-up, and you can appreciate there is a well-fixed implant, well-aligned implant, and she is doing well with the knee range of motions and full weight bearing ambulations. After 1 year follow-up, these are the X-rays of after 1 year follow-up, you can appreciate it a well-fixed implant as well. And patient has no active complaint, patient has no recurrence and no other metastatic lesions. These are the images of 4 year follow-up. Patient is asymptomatic and patient is doing well. These are the 8 year follow-up X-ray images. And this is the same, you can appreciate when fixed implantation is doing well. And then this is a 10 year follow-up, recent images, which is fixed implant, patient is doing well, and there is no recurrence of disease, and there is no other metastasis. These are gait with range of motions. These are range of motion. It has normal gait.
कैसी हैं आप? सभी ठीक है?
Patient
कब हुआ था आपका ऑपरेशन?
is well satisfied
अच्छा, उससे पहले भी आपका ऑपरेशन हुए थे?
जी मेरे 2 सर्जरीज हुई 2006 में और 2008 में। और
क्या मसला था?
उन्होंने कहा था कि टांग में ट्यूमर है, तो उसको रिमूव करने के लिए ऑपरेट किया था। और मेरे 2006 में एक साथ 3 ऑपरेशन हुए थे, और 2008 में भी जो है वो बोन ग्राफ्टिंग और बोन सीमेंटिंग हुई है 2008 में।
और फिर दोबारा पैदा हो गया?
जी 2011 में रिकर हो गया दोबारा। और उस डॉक्टर ने उस दौरान कहा था कि आपकी, डॉक्टर से पहले जिनको मैंने दिखाया था उन सब ने कहा था कि आपकी टांग कटेगी, आपका काफ़ी सीरियस इशू है, काफ़ी
बढ़ गया था।
जी।
और चेस्ट में भी, फेफड़ों में भी?
जी चेस्ट में भी ट्यूमर डायग्नोस हुआ था, उसका कुछ
यही वाला ट्यूमर वहाँ चला गया?
लाइन सेल ट्यूमर वहाँ सर्कुलेट करके चला गया था, उसके बाद उसकी भी सर्जरी हुई।
2011 में हमारे पास आपकी टांग की भी हुई सर्जरी और चेस्ट लंग्स की भी हुई।
जी।
तो 11 साल में अब आप कैसी हैं?
अब मैं बिल्कुल ठीक हूँ, शुक्र अल्हम्दुलिल्लाह। मुझे किसी किस्म का कोई प्रॉब्लम नहीं है, ना नी में और ना ही चेस्ट में।
तो आप जॉब करती हैं, अपना जाना आना सब सीढ़ी चढ़ लेती हैं, सब
अल्लाह का शुक्र है, बिल्कुल ठीक है।
किचन का भी मैनेज कर लेती हैं?
कोई मसला नहीं है, मैं बिल्कुल ठीक हूँ अल्लाह का लाख
तो अपने घुटने की मूवमेंट से आप मुतमईन हैं?
बिल्कुल बहुत मुतमईन हूँ, अल्लाह का शुक्र है, बहुत अच्छी मेरी सर्जरी हुई है।
और ट्यूमर वापस तो नहीं आया इस दौरान?
नहीं, ट्यूमर वापस नहीं आया। थैंक यू।
Thank you. Any comments and remarks? Yes. This is the early case in which initial 2011 we got the literature suggest denosumab, and denosumab is coming from the recent. तो अब हम जो है GCT में denosumab को consider करते हैं, और initially this is the prior case 2011, उस वक्त इतना literature visible नहीं था denosumab which is not चेस्ट के लिए तो
one layer you can remove from it. Whether written as legislation, the grant and development definitely will somehow written, somehow if you're single layer, so that will remove more diseases. So we have related intent to different order. This is the thing there.
Yes. With no further questions, we'd like to invite Dr. Malik Sahib to present the case.
Assalamualaikum. Sorry about the interruption. Previously, I'm Dr. Marej, and I'm going to present a total scapulectomy, and this work was done by Dr. Masood. So it is a 7-year follow-up of this total scapulectomy. So initially, he was a patient, is a 37-year-old gentleman who presented with a history of left shoulder pain for 4 months. On workup, the X-ray showed left scapular lytic lesion with soft tissue component, and CD guided biopsy was done on 25th April 2014, which showed GCT of left scapula. Metastatic workup was negative. So these were the pre-op X-rays of this patient showing a large osteolytic lesion at the left scapular region involving the glenoid, involving the whole of the scapula, acromion process as well. So we planned for a total scapulectomy on 12th of May 2014. This was a specimen radiograph which involved almost all of the scapula. So we planned for a total scapulectomy. Other options for the scapula are total are the glenoid preserving scapulectomy and acromion preserving scapulectomy, both acromion and glenoid preserving scapulectomy and resection of the lower half only. So that depends upon your level of the case and level of your involved lesion. So these were the post-op X-rays. So the remnant, the clavicle was adhered to the humerus with a fiber tape, with a Mercelin tape initially. And so in August 2014, patient presented with humeroclavicular instability. And now you see the distance as compared to the previously has increased, and this patient has decreased, has difficulty in moving his limb, even lifting heavy weight. So it was had a 3 millimeter or 3 centimeters of displacement. So we planned for open reduction and claviculohumeral reconstruction with Mercelin tapes, and intraoperative finding was that previously construction of the ligaments were severe. So these were the X-rays of the patient 7 years down the line from the previous surgery. So it showed a good contact between the humerus and the clavicle. So I'm going to show this is a scar of the patient. This is a longitudinal scar of the patient for the scapula, scapulectomy. So I'm going to show the video of his routine. So we can appreciate this patient moving has a forward flexion of 0 to 90, and he can extend of a bit 30 degrees too. The internal rotation is adequate to reach his chest and opposite shoulder. He can wash his face. He can make his beard as well, as you can see here. So, or he can eat with this. So he showed every gesture of his for his outcome. Yeah. So he can move his hand towards the back. So that was all. So he had limited over abduction, and he used his other hand to for overhead abduction. Yeah. So this patient voluntarily made this video, and we told him to use. We would use it as a educational purpose. So I found some. This is the article I found as a factor that influence functional outcome after total or subtotal scapulectomy. Japanese Musculoskeletal Oncology group study. So they included some amount of patients, and which included 26 scapulectomies, and others were some of the part of scapula was preserved. So this is an important slide. So they thought about reconstruction versus no reconstruction. No, this is I'm talking about the soft tissue reconstruction. So on the white bar shows those with no reconstruction, and those with the dashed line shows with the reconstruction. So there was no statistically different no statistically difference there between any functional outcomes. In regards of pain, functional, emotional acceptance, hand positioning, and lifting ability. However, there was a statistically significant difference in the dexterity. What that dexterity is the use of small hand joints and fingers. So this was all, and this score compiles the Enigen's musculoskeletal score. So that was all from the side. So any questions? So we call it as a suspension plasty to attach the clavicle to the humerus via Merslin tape, or now it is a fiber tape. This was around 7 years back. Any questions from the audience? Okay, I will move to the next case. Yeah. Yeah. How much weight he can carry? So it was used for intermediate. The score was intermediate, as well as weightlifting ability was intermediate. Around 1 to 2 kgs of weight he can lift it easily. More than that, yes, he has got issues with that, with causing us or lifting heavy weights. Yes. So for the daily life, he's used, and he's right-handed, so he uses most of his work. He does most of his work with his right hand. So he's adapted to that for quite a long time now, and so that's it. Thank you.
So the next presenter is Dr. Omar.
Assalamu alaikum. So my name is Dr. Sayyid Umar Rafiq, and today I'm going to be presenting a case under the supervision of Dr. Masood Umar. Bismillahirrahmanirrahim. So this is a case of a 37-year-old lady with no known comorbids. She had a complaint of pain in the right thigh for 2 years. She had no history of fall or trauma. The pain was mild to moderate, and it was gradually worsening with time. There was no history of fever, and there was no history of weight loss. So initially workup was done. The radiographs showed a lytic lesion in the right femur shaft, and MRI was done to further evaluate the lytic lesion on the 28th of April 2016. These are the MRI images. As we can see that there are signals in the intramedullary canal of the right femur. The signals are quite extensive, about 10.6 centimeters of the femur shaft. And there is no cortical breach, and there are no signals in the adjacent soft tissues. So open biopsy was performed on 7th May 2016, which reported grade 1 chondrosarcoma. Metastatic workup was done, which was negative. These are the radiographs which were done in the OR. And here we can appreciate that a lytic lesion is involving the distal part of the femur shaft. We performed intralesional curettage of this lytic lesion plus phenolization and femur plating. Actually, a window was being made in the bone, and extended curettage was done using high-speed burr, which was then washed with phenol, absolute alcohol, and then a long plate was applied to provide stability to the femur. These are the immediate post-operative radiographs, and these are the radiographs 6 years down the line. And here we can see that a good solid bone has formed, and there are no signs of recurrence, there are no signs of implant failure, and the patient is doing pretty well, as evident by this video. She presented to us last month, and as you can see, she had a good range of motion in the hip and knee joint, which is comparable to the other leg. Also, she has absolutely normal gait. There is no limping, there is no pain, and she is pretty satisfied with the surgery. Briefly going through the management of chondrosarcomas, if the long bone is involved and it is a low-grade lesion, like a grade 1 lesion, so intralesional curettage plus adjuvant therapies will suffice as the only treatment. But if it is a grade 2 or grade 3, then wide margin excision is mandatory. And in cases of axial skeletal involvement, then wide margin excision is necessary in all these cases. So I came across a paper published in the Journal of Orthopedics and Traumatology in 2013, titled Surgical Treatment of Central Grade 1 Chondrosarcomas of the Appendicular Skeleton. So this was a retrospective review of 85 patients, and of which 64 patients underwent intralesional curettage and 21 patients were treated with wide margin excision. This was a 67 months follow-up, and only two patients developed local recurrence in both the intralesional curettage group, but the difference was not statistically significant between the two groups. So the author concluded that low-grade chondrosarcomas of the appendicular skeleton without aggressive radiological patterns can be treated with intralesional surgery, with low chances of recurrence and lower morbidity to the patient. Another paper titled Intralesional Curettage of Central Low-Grade Chondrosarcomas, a midterm follow-up, concluded that extended intralesional curettage has the benefit of good MSTS scores, shorter operative time, shorter hospital stay, and lower complication rate without increasing local recurrence in the central low-grade chondrosarcomas. So thank you. And this was the 6-year follow-up of our case.
This is the last presentation. Thank you all for joining us for this event. Thank you. You can take your lunch boxes outside the auditorium.
So there is an announcement. Next monthly meeting will be at Address Hospital on the month of July, and the most probably date would be 30th of July. Thank you.
Huh?